septic shock, and we're going to follow an outline from the surviving sepsis document. This is actually something online you can download if you like and print out. And it's evidence-based like surviving sepsis is. And the two main bullet points are norepinephrine is the vasopressor of choice, and a target map of 65 millimeters of mercury is your target, and higher isn't better. There's other points. You can see these have these little triangles with the exclamation points. That invasive monitoring with an arterial line. I know Hallie Gershengorn, University of Miami, never puts them in. Peripheral vasopressors, I'll talk about that information. Vasopressin, I'll talk about that. And then the issue of cardiac support with dopamine, we'll talk about that. So in surviving sepsis, norepinephrine is preferred to dopamine. This cut and paste from the figure you see shows that the evidence for dopamine, I'll show you that in just a minute, is strong. It's high quality evidence. When I was a resident, we used dopamine, and that has changed. The evidence for superiority of vasopressin, less strong, but still adequate. I'll share that with you a little bit, although it's complicated. And there really is not a lot of comparative evidence for epinephrine, citalopressin, or angiotensin II. In resource-limited environments where norepinephrine is not available, epinephrine or dopamine are fine. I mean, it's better to have something than nothing, right? Although surviving sepsis emphasize that norepinephrine is the superior agent and one should strive to have it. The reason norepinephrine is preferred to dopamine is better vasoconstrictor and with fewer arrhythmias. And in fact, the issue of arrhythmias was shown. This was all kinds of shock. Cardiogenic shock was included. This was not just septic shock. This paper's old now. It was a randomized trial with no mortality difference, and there were more arrhythmias in the setting of dopamine, particularly overall, but there was a higher mortality in the patients who had cardiogenic shock who received dopamine. In terms of mean arterial pressure, this was a study now from 2014 in the New England Journal. There is no benefit. This looked at a target of 65 or higher. As you see, the higher pressures to the left in the diagram, the higher target group around 85 with no mortality benefit. There was recently a meta-analysis that confirmed no mortality benefit. There was a suggestion that perhaps patients with chronic hypertension might benefit from a slightly higher mean arterial pressure target, but overall, certainly no mortality benefit to a higher mean pressure. And these are the strong points pointed out to you in the surviving sepsis document. In terms of peripheral vasopressors, how many people use peripheral vasopressors in septic shock? Well, not too many hands are going up. But this is a popular trend in the United States. When you actually carefully look, as this review, this systematic review meta-analysis did, at the evidence is actually not very good. And in fact, these are mostly patients who had norepinephrine for less than 24 hours at a low dose. I mean, that's the synopsis here. In other words, really, if you look at if the numbers were included overall, and this is all the literature on this, not a lot of people are on it for more than 24 hours, and not a lot of people at higher doses of 0.13 micrograms per kilogram of norepinephrine, which is not a lot, right? That's not a lot of norepinephrine. When it comes to other agents, such as phenylephrine or epinephrine, as you see, 12% of the overall patients. A small population, vasopressin, not much at all. And I will tell you, though, I was recently at the Society of Critical Care Medicine meeting in San Francisco where a show of hands showed a lot of people using this. So I don't really have a good feeling for this yet. We do use this as a bridge, right? I mean, many patients can come off pressor quickly, and you have to strategize as to whom that patient population is. But in terms of literature support, high doses for long durations of agents not named norepinephrine do not exist, or even including norepinephrine for high dose longer. Now, vasopressin, we've had this agent for many years, and I kind of thought when the VAST trial came out in 2008, this kind of put a damper on its use. The issue here was patients that were norepinephrine dependent at 6 hours had vasopressin added or randomly got more norepinephrine. And in fact, there was no mortality benefit seen. There was potentially a mortality benefit seen in post hoc analysis of those who were on a little bit of norepinephrine. So everyone thought that if vasopressin would work, it was when the norepinephrine wasn't working at a high dose and you add it. No, those that were at 6 hours on less than 0.15 mics per kilogram of norepinephrine seemed to benefit. So I kind of thought, well, who's going to add it? Just give norepinephrine. But post hoc analysis showed that perhaps the concomitant use of vasopressin would be less likely to go on to progressed to renal failure in those who had, by rifle criteria, renal insufficiency. It is true that vasopressin, separate paper, you see the JAMA paper from 2016, early use of vasopressors with corticosteroids did not result in less AKI compared to norepinephrine alone. So the issue of kidney injury is still up in the air. Now, Surviving Sepsis did take a take on this, which is one that I think has permeated my residents at my hospital, based on some observational data. I mean, the VAST trial is a randomized trial, but there is observational data you see here that the earlier addition of vasopressin to norepinephrine might be associated with a lower mortality. This is observational. So I don't know what quite to make of that. Certainly we know from VAST that those that got it at a 0.15 dose or less seemed to benefit. So that's kind of an echo of that sentiment, of that finding, but not a firm one. But Surviving Sepsis took a tack that I was a little surprised to see. They said in our systematic review of 10 randomized trials, vasopressin plus norepinephrine reduced mortality. Now, it's funny that they didn't actually publish that meta-analysis itself. It was kind of embedded in Surviving Sepsis, but I'll take their word for it. I mean, these are all good people. But they said that actually, not just taking VAST into account, but all the literature suggests an improvement, and perhaps early is better. There was no difference in digital ischemia, and it did not reduce the need for renal replacement therapy. So the kidneys are not protected by vasopressin, and digital ischemia is not worth vasopressin, and mortality may be enhanced. So they suggest adding it early. And how early? Well, in the range of 0.25 to 0.5, which is interesting as well, because the only literature I knew was under 0.15 at 6 hours. There was mortality, but the only prospective data. So be that as it may, I'm willing to cave. All my patients end up on vasopressin, I swear to you. And I think that the evidence out of Surviving Sepsis it's clearly their bias. I'm not necessarily sure I share it. In terms of inotropic support, we've heard a little bit from Dr. Rodriguez about hemodynamic monitoring, but certainly if you have cardiac dysfunction despite adequate volume replacement, the problem is, what is that? How do we know that? But you should add inotropic support with dobutamine, perhaps preferred over norepinephrine. It is a weak recommendation, low quality of evidence. Again, now what is volume responsiveness? I think that is one of the holy grails of sepsis resuscitation. So how do we know you need it? And again, the definition of volume repletion remains problematic with the PA catheter use, as Dr. Rodriguez pointed out with your show of hands, no longer prevalent, if at all used. Dobutamine and epinephrine are equivalent in terms of network meta-analyses in this setting, and certainly in resource-limited environments, epinephrine would be acceptable inotropic support because it has more cardiac stimulation and less peripheral constriction. So what have I told you? Norepinephrine is the first-line drug. Certainly in resource-limited environments, if you don't have it, dopamine is fine, but norepinephrine is preferred. Target pressure of 65 or more with mean arterial pressure, and really no benefit to aiming higher. Initially, low-dose vasopressors are adequate if you are bridging to either getting the patient entirely off, or you think you can realistically, or while you're getting the patient a central line. But really going further rather than 24 hours, you're kind of on your own. We don't have that data. The earlier addition of vasopressin and norepinephrine is probably beneficial and probably not harmful when administered centrally, and I would argue no peripheral use. There's really just not good evidence for that. I worry about that, although show of hands I saw at Society of Clinical Medicine, people said vasopressin peripheral, no problem. I personally wouldn't endorse it. Adding dobutamine, epinephrine, if you don't have it, if hypotensive, despite adequate filling pressure, whatever that is a good idea. And that's what I have for you. I think that is my last slide. Thank you.